And my agenda will be to talk about the developmental challenges on how ADHD changes, and the face that you see it might be different, and that's they might be very difficult to diagnose and differentiate. Um, but not just differential diagnosis, but sometimes you have comorbidities. So it's not you have one or the other. Sometimes you have both. And then how to assess symptoms, a little bit on how do I do it and what do I do in clinically, and also evidence-based, as far as how to know where to start when you're starting treatment. So ADHD changes through the lifespan, and you have impulsivity that is going down from preschool to early adults, although it doesn't go down all the way. Hyperactivity goes down in adolescents, and then inattention tends to go up. So depending on the moment where you see the patient, you're going to see a different set of symptoms. And it might be very, very different. And as it was mentioned before, if you see girls, they're probably going to be more inattentive, and then they might be transparent, and as Mr. Lavie mentioned before. And in adults, the picture would be a little bit different. And then you have increasing frequency in the comorbidity and added complications. You have the different patterns of presentations between boys and girls, although still, like the combined subtype is the combined presentation is the most frequent in females, but you still have the inattentive presentation that is quite frequent, almost a third of the girls. All right. So you need to make a differential diagnosis, and that needs to be done from the developmental perspective. So sometimes I write a diagnosis as ADHD versus high activity for his age, but not necessarily hyperactivity. And then developmental or situational anxiety, because anxiety is very frequent in young kids, which is when ADHD is starting. And then from the psychosocial point of view, a history of abuse or neglect or deprivation, understimulation, and on the other hand, overstimulation or lack of structure. And we have seen this in the COVID pandemic with a lot of parents leaving the whole free day for the kids that are using all the day playing on their screens, on their computers or phones, and then going to bed at 3 o'clock in the morning. They're having problems, telling me in the clinic that this kid is not doing well in school. Of course, if you go to bed at 2 o'clock, you're not going to do your online schooling. And then there's a medical set of differential diagnosis that I think is frequently overlooked. So, and I'm fortunate to work in a clinic that is called Integrated Behavioral Health. So I work directly with the pediatrician. So I have the pediatrician right there, and we are in the same floor with the pediatricians. And I can tell them to have a look at this kid if some of these issues haven't been addressed. Most of the times they've been addressed before, and I know what are the medicines that they take and what are the, if they have epilepsy, they have any diabetes or any genetic problems, etc. These are some of the syndromes that I see on a day-to-day basis. So I see very, very severe cases of genetic syndromes, and that they have on top of that behavioral or attentional or executive function problems, right? And then you have to do a psychiatric differential diagnosis that is going to be with disruptive behavior disorders, which frequently come together with ADHD, mood or anxiety disorders, including bipolar spectrum that have been under-recognized, but also psychosis, substance use that is frequently also overlooked in adolescents. And then, although it's not very frequent, but sometimes you get the sense that the parents want a diagnosis because they're looking for something other than the clinical care, and that you have to be aware. But that's not very frequent in my experience.